The next section of the talk is really a subset of discussion of heart failure, and I thought it would make some sense to discuss a little bit about specific cardiomyopathic entities that may come up in your board study. I'm not going to reintroduce myself. I think you've gotten to know me over the day. So there are three objectives for this section, really. One is to talk a little bit about the entity of dilated cardiomyopathy and why we care about the specific etiology. I want to talk a little bit about the pathophysiology, diagnosis, and risk stratification of patients with this important entity of hypertrophic cardiomyopathy. And then I want to talk a little bit about some infiltrative cardiomyopathies that are important entities to know about as you think about questions on the boards. So let's start with dilated cardiomyopathy, and this is a very broad entity. And on the single slide here, I've tried to give you a sense of the breadth of causes that give you that same phenotype at the end. Remember that still far and away the most common cause of an enlarged heart with left ventricular dysfunction is ischemic heart disease. That's about 40% of cases. About 12% of cases are related to undiagnosed or progressive complications of valvular heart disease. And still about 11% of patients have end-stage complications of hypertension. But this still leaves us with about 40% of patients where we have an enlarged heart, no coronary disease, and we're not quite sure why it's happened. And the breakdown of causes of that entity, which some have called idiopathic dilated cardiomyopathy or dilated cardiomyopathy, is really listed on the slide. And I think increasingly important in that group is the entity of chemotherapy-related cardiomyopathies. The paradigmatic entity there is adriamycin or daunorubicin or doxorubicin, but there are a number of other new chemotherapeutic agents, including immune checkpoint inhibitors that have been implicated, a range of other disorders, and we'll talk about some specific entities, including toxin and peripartum cardiomyopathy, as well as myocarditis. But even after we've done an exhaustive search, there's still about half of these cases that are unexplained, and those are idiopathic cardiomyopathies. I think the role of genetics is increasingly relevant because we're learning that probably about 40% of those patients with an idiopathic cardiomyopathy that was previously unexplained probably have familial disease. And as our genetic screening gets better, we're better at isolating the specific causative entity in those cases. So why do we care about etiology? Well, we care about etiology in large part because the etiology is related tightly to prognosis. Patients with peripartum disease, for example, have an excellent prognosis with medical therapy as long as they don't have recurrent pregnancy, whereas patients with cardiomyopathy due to infiltrative disorders have a much more progressive and downhill decline. And so it does matter how a patient got to the same phenotype. I want to show you a case. This is a 50-year-old man who has a history of hypertension and dyslipidemia who comes in with 3 months of progressive dyspnea. He has no prior MI and denies chest pain. He takes atenolol 25 milligrams daily and simvastatin 20 milligrams once daily and drinks a glass of wine with dinner. He denies any tobacco or illicit drug use, and his family history is notable for a paternal uncle who died suddenly in his 50s. On exam, his blood pressure is 170/80, and the rest of the exam is as written on the slide. His electrocardiogram shows sinus rhythm with a left bundle branch block, and he has a dilated left ventricle with an ejection fraction of 25%. So with that in mind, which of the following factors is least likely to be responsible for his heart failure? Is it A, uncontrolled hypertension, B, coronary artery disease, C, alcohol use, D, genetic factors, or E, myocarditis? So you're voting now. All right. So just to move through here, it looks like most are voting for myocarditis as the least likely, and some for alcohol use. So the intended answer to that question was alcohol use, and it's principally because really it'd be difficult to exclude myocarditis as an etiology of cardiomyopathy. I think a lot of patients with dilated cardiomyopathy probably did have a history of myocarditis that was undiagnosed and may have healed and left them with some residual LV dysfunction. But alcohol use, when it causes cardiomyopathy, is typically associated with a pattern of regular high-dose alcohol consumption. Typically, That's more than 4 to 5 standard drinks a day over several years. So somebody who's drinking a glass of wine with dinner, unless it's a very large glass of wine, is probably not likely to be developing cardiomyopathy on that basis. I think there are a number of other drugs of abuse as you study for the boards or get stems of questions to keep in mind, including cocaine and amphetamines, which are certainly recognized as potential causes of cardiomyopathy. I told you that anti-cancer drugs are an increasingly important entity to consider, and I've listed a few key offending agents on the slide, but that list is really expanding on a regular basis. There are a few other drugs to know about. Hydroxychloroquine in this day and age is one to keep in mind and certainly can be associated with ventricular dysfunction and cardiomyopathy. Clozapine, used as an antipsychotic, can be associated with LV dysfunction and cardiomyopathy. And certain toxins, including heavy metals such as cobalt and other solvents, can be associated with the development of left ventricular dysfunction and cardiomyopathy. So a few things to work through in your mind, and a detailed history of physical is clearly important. The second case here, this is a 25-year-old man who presents in transfer to your hospital with a low ejection fraction. He's intubated and has a balloon pump in place. He was completely healthy until 4 days prior when he developed a flu-like syndrome. In fact, he ran a marathon a couple of weeks ago. So his history is notable for growing up in Guyana. He moved to Connecticut a few years ago. Maybe he had a tick bite. He's otherwise healthy. So my question to you is, what's the most likely etiology of his cardiomyopathy? Is it A, trypanosomiasis, B, toxoplasmosis, C, a Borrelia infection, or D, Coxsackie virus B? All right, so I think here that the vast majority are voting for Coxsackie virus and are saying this is a viral cardiomyopathy related to polymyocarditis. I think I was trying to put some teasers in there about Chagas disease, but it's still far and away the most likely cause of cardiomyopathy. If you think myocarditis is at play, is a viral entity, and Coxsackie virus is high on that list. Remember that myocarditis is defined based on the clinical presentation, and this is a pretty classic presentation. An acute onset heart failure, a viral prodrome may or may not be present. Typically, patients have chest pain and elevated cardiac biomarkers, but they may not always be there. ST segment abnormalities would help to cement the case, particularly in the absence of coronary disease. And you might enhance your diagnostic ability if you can do a cardiac MRI to identify late gadolinium enhancement or myocardial edema. And you can really nail it with endomyocardial biopsy, demonstrating the relevant histopathology of lymphocytic infiltration. A number of etiologies are implicated, but most commonly they are viral. And we think about Coxsackie virus, parvovirus, and HIV as potential entities. Remember, COVID-19 is now on this list as well. Bacterial causes are pretty less likely. Borrelia infection, Lyme, can be a cause of infectious myocarditis. And there are a number of other causes. In Latin America, trypanosomiasis with Trypanosoma cruzi infection is a major cause of Chagas disease, behind ischemic heart disease, the leading cause of cardiomyopathy in patients where this disease is endemic. And a few other things to consider: hypersensitivity myocarditis, drug-induced or eosinophilic, and autoimmune diseases, which can be associated with autoimmune myocarditis. I think I'm going to shift just for a moment to a couple of other entities that I want to make sure you're exposed to. One is this etiology of peripartum cardiomyopathy, which is heart failure without other obvious etiology that occurs either a month prior to delivery or up to 5 months after. We're starting to realize these may occur even earlier in pregnancy, but the intent of defining this time frame is to differentiate this from cardiomyopathy that existed prior to pregnancy, but is awakened by volume shifts and diagnosed earlier in pregnancy as a consequence, not directly of the pregnancy, but unearthed, if you will, by pregnancy. This is a peripartum disease, which is cardiomyopathy induced by pregnancy, is a rare complication, about 1 in 2 to 1 in 4,000 live births in the US. And there are a lot of etiologies that have been discussed, but the recent scientific data suggests that this may be related to antivascular effects of late pregnancy, particularly the late release from the placenta of soluble FLT1, which is an entity entity that scavenges vascular endothelial growth factor and may cause some endothelial injury. This may be made worse by the antioxidant stress of heightened prolactin levels. What do we think about who gets peripartum cardiomyopathy? Well, you should think about peripartum disease as being as higher risk in patients who are older, who have who are multiparous women, people who have multiple pregnancies. African Americans are at higher risk than non-African Americans, and hypertension and preeclampsia may be early premonitions of this disorder in subsequent pregnancies. There's some question as to whether there may be some association with maternal cocaine use or prolonged tocolytic use with beta agonists, but those associations are less clear. Why do we care? Well, I think there are a lot of reasons that this entity is important. One is that for many women who get this in the peripartum period, there is recovery of ventricular function, over half. But for some women, this results in persistent ventricular dysfunction and may progress to the need for cardiac transplant and rarely mortality in the United States. And these are numbers from a relatively older series, but I think even now we have some patients who do get quite sick with this entity. And the most common question that comes up is really who's going to do badly, who's going to do poorly, and what happens with subsequent pregnancy. I think I want to just draw your attention to this data from Dennis McNamara, which really suggests that the EF at the time of presentation tells you a lot about the likelihood of subsequent recovery, and outcomes are clearly much worse in those with severe LV dysfunction at their initial presentation. Outcomes tend to be a bit better with a much higher proportion of recovery in those with an EF of 30% at the time of presentation. And the reason that recovery of ventricular function is so important is that we know the risk of subsequent pregnancy in these women is much lower if they have recovery of ventricular function in between pregnancies than if ventricular function remains suppressed. And the big concern if ventricular function remains low after a first pregnancy is that if women become pregnant again, there's a very high risk of fetal loss and maternal morbidity and mortality, recurrent heart failure, that is even more severe than with the first pregnancy if that happens. And so the counseling in women whose LV function does not recover is to really take precautions against subsequent pregnancy. But women who do recover are probably able to move forward with subsequent pregnancy. Hypertrophic cardiomyopathy is another important clinical entity, and I think is a complicated discussion, but let me just walk you through a few aspects. The diagnosis of hypertrophic cardiomyopathy is suggested in a patient with unexplained left ventricular hypertrophy. On biopsy, the pathologic hallmarks are myocyte disarray and fibrosis, reflecting abnormalities of the sarcomere at the genetic level that result in sort of malformation of the myocardium. We don't often biopsy those patients, but that's what you might see. Most patients with this entity have normal longevity, but for some patients, this is a devastating problem that may result in early sudden death in young people or in progressive heart failure over time. The prevalence is fortunately low, but this is one of the more common cardiovascular genetic entities that we see in cardiology practice. Now, it's a disease of the sarcomere, as I mentioned, related to genetic abnormalities in any of a number of genes that constitute the myocardial contractile apparatus, hundreds of mutations described. The main thing that's important is that because it's genetic, one needs to think about not only the patient in front of you, but also the associated family members who may be at risk. The management is really focused on three aspects. One is management of symptoms. The second is risk stratification for sudden death. And the next is treatment of the family. So let's think about symptom control first. And in general, the approach to therapy in HCM is that if there are no symptoms, there is no therapy. We have no disease-modifying therapy as yet, although there is some new data about a drug called mavacamten that may provide some opportunity to modify disease progression over time, but that's early. For now, though, if your patient is asymptomatic with HCM, they don't get treated. If they have symptoms, the question then becomes, do they have hypertrophic cardiomyopathy with obstruction, or do they have non-obstructive hypertrophic cardiomyopathy? Well, what do I mean by that? Well, about 70% of patients with hypertrophic cardiomyopathy have dynamic obstruction from the septum and the anterior mitral leaflet of the left ventricular outflow tract due to systolic anterior motion, that's called SAM, of the mitral valve. And this results also because of drag from that jet leaving the ventricle on the anterior mitral leaflet and some mitral regurgitation. Another proportion of patients, because the ventricle is formed abnormally, have diastolic dysfunction and are short of breath on that basis, even in the absence of obstruction. And then these things may be compounded by other factors. But when there is obstruction, you have a lot of load on the ventricle, and that may contribute to subendocardial ischemia. I mentioned mitral regurgitation from systolic anterior motion of the mitral leaflet, and there's obviously a diminished cardiac output because so much force is expended to push blood flow through a narrow passage. And then I think when there's diastolic dysfunction, there's high left atrial pressure, and patients may go on to develop heart failure. And over time, this disease may burn out and result in diminished cardiac output. And all of these things conspire to give the myriad symptoms of fatigue, chest pain, dyspnea that will characterize the symptomatic presentation of patients with HCM. So when we think about therapy of patients with HCM, we're really thinking about management in the outflow obstruction patients of outflow obstruction. So to understand this, you need to know that outflow obstruction in patients is related to the amount of contractility, the amount of afterload, and the amount of preload, with worse obstruction when patients have lower afterload or more vasodilation or less preload. So if they're dehydrated or the ventricle becomes smaller. And this is one of the reasons that HCM patients who have obstruction are so much worse on exertion, because the heart rate goes up, the afterload goes down because of systemic vasodilation, and volume goes down because of less filling. So once we establish the mechanism, the slides will give you an approach to therapy, and I won't dwell on this, but in general, we're giving therapies that may modify heart rate, reduce contractility, agents like beta blockers and calcium channel blockers, and if there's congestion, we give diuretic, and those patients with refractory symptoms are then referred on. In the patients with obstruction that is symptomatic, we try to prevent factors like vasodilators that can exacerbate the obstruction. We do try to avoid drugs like ACE inhibitors, dihydropyridine calcium channel blockers, other vasodilators, because those things make obstruction worse. And then we try to limit the obstruction, the impact of obstruction by slowing heart rate and contractility. There's role potentially for negative inotropes like disopyramide. And then here, the other consideration is whether patients need septal reduction to relieve the obstruction, either with alcohol septal ablation or myectomy. And that's really beyond the scope of this talk, but just know that that option is available for patients who have severe obstruction and are refractory to medical therapy. I mentioned the second component here is really focusing on risk stratification of patients for sudden death, because that is a devastating complication of this illness. And to do that, you need to know that there are a number of features that are associated with higher risk for sudden death, including syncope, a family history of a sudden death event, particularly in a first-degree relative, severe hypertrophy, and a hypotensive response to exercise. Some evidence that non-sustained ventricular tachycardia on monitoring may also do this. And the more of these factors you have, the higher the risk of sudden death, and potentially the more likely it would be that we would recommend that patients get a defibrillator. And I'll leave this for your study, but there is a nice algorithm here that really is driven by assessment of the risk factors and recommends defibrillator implantation in those who've survived an arrest or have sustained VT, and then consideration of an ICD in those who have the highest risk features. In other patients, it becomes a little bit more of an individualized discussion because the role of ICD is less clear. But it is a challenging problem because we have patients who are often young and we're trying to prevent a devastating complication. And so we often err on the side of sudden death prevention and protection. Finally, this is a disease not just of the patient in front of you, but also of the family. And so counseling and family screening are critical, and we need to make sure that at least all first-degree relatives are aware of the diagnosis and undergo appropriate counseling. Some may require genetic testing, and certainly all will require clinical screening. Exercise is the other issue that comes up in management of these patients, and in general, this is a matrix of exercise according to intensity by static and dynamic components. The message in general is that for people with hypertrophic cardiomyopathy, we want to be on the lower left-hand corner of this matrix, giving people moderate exercise conversational pace, avoiding burst or sprint activity, and really avoiding isometric exercise and heavy weightlifting, because we think these can exacerbate obstruction and precipitate risk for sudden cardiac death. I think the other features here to consider are other things that might mimic hypertrophic cardiomyopathy, including physiologic left ventricular hypertrophy. So the athlete's heart may be a differentiator. Patients who have renal failure may have a lot of hypertrophy. Those with uncontrolled hypertension might have a lot of hypertrophy. Those with infiltrative diseases or storage diseases might have hypertrophy. So don't think that every thick-walled patient has HCM. Think about the mimics that might be confounding the disorder. And one of the key ones is cardiac amyloidosis. And I think we're increasingly recognizing this thing we thought was a pretty rare entity is actually more common than we realized. There's still a small incidence of AL amyloidosis, which is light chain amyloidosis related to an underlying plasma cell dyscrasia in the variant, if you will, of myeloma. A large fraction of these patients have cardiac involvement, but this is a cancer-like entity. What's more common and increasingly relevant is variants of a different type of amyloid related to transthyretin, or TTR. And there are two types. One is a familial variant, which is a mutant protein, transthyretin, produced by the liver. 4 to 5% of African Americans are carriers of genes that might contribute to this. This disease might also be associated with significant peripheral neuropathy. And then there's the wild type entity we used to call senile cardiac amyloidosis that is certainly increasingly recognized as a confounder of the diagnosis of HFpEF. So when to suspect amyloidosis, I think in general, we want to think about this entity in patients with heart failure without hypertension, those with unexplained right heart failure, those with dysautonomia. Think about bilateral carpal tunnel syndrome or biceps tendon rupture as a clue to amyloidosis. And for AL disease or light chain disease, patients may have a thick tongue, big shoulders, and a lot of periorbital bruising. On imaging, you want to identify that patient who has the discrepancy between low voltage on the ECG and a large mass on imaging. That voltage to mass discrepancy is a big clue for amyloidosis. And then there are a lot of other imaging clues that are listed on the slide, including specific findings on echo and MRI that you should think about. Amyloidosis is defined pathologically by confirmation of either either light chains or evidence of the characteristic apple-green birefringence on endomyocardial biopsy, and this is an example of that on histologic H&E, and then the birefringence on staining. One other way we identify TTR amyloidosis increasingly is using bone scintigraphy. This is a bone scan where the heart lights up, and this turns out to be a fairly sensitive way of detecting TTR variant amyloidosis, the senile variant of amyloidosis, not so sensitive for AL amyloidosis, but something that could come up on exam. So the treatment here really depends on the type. We treat congestion and volume overload. If patients have AL disease, the treatment's directed at the plasma cell dyscrasia. They have TTR disease. Really, we're talking about not many disease-modifying entities until recently. We now have drugs like tafamidis, or in some cases, drugs that maybe interfere with the production of TTR that are RNA interfering drugs that are being explored. But for now, this is an entity that requires referral for treatment to a specialized center. Finally, I'll just mention briefly sarcoidosis because I think we're coming to the end of time. This is an entity that is still poorly understood. It's an inflammatory disease of unclear etiology that is characterized by the hallmark non-caseating granulomas, distinguished from the caseating granulomas of tuberculosis. Typically, the onset is prior to age 60 with higher prevalence in certain ethnic groups. This is a systemic disease that may have lung manifestations, lymphadenopathy manifestations, eye manifestations, skin manifestations, but can also involve the heart in about a quarter of patients. And the classic presentation is with heart block or ventricular arrhythmias in association with LV dysfunction and heart failure. Sometimes this is a disease only in the heart and not elsewhere in the body, but it's often part of the standard. And the only way to definitively make this diagnosis is through endomyocardial biopsy, but sampling errors challenges that approach to diagnosis because the disease can often be patchy. So often we rely on MRI and PET scanning to help influence our diagnosis. And when there's a lot of scarring in the heart by MRI, a lot of inflammation in the heart by PET scan, in the right clinical scenario, we should suspect sarcoidosis. The management here is directed at treatment of the underlying immune disorder, immune suppression, typically with prednisone, but occasionally with steroid-sparing agents. And the other is this disorder, when it involves the heart, carries with it a high risk of sudden death. So patients who have high-risk features like VT or a low ejection fraction should be considered for early use of defibrillators. So I'm going to close there because I want to get us back on time. I know we went through that quickly, but I'm happy to take any questions you may have.